This is the only video you need to know every detail about the P wave. So whenever we see the P wave, first thing to look out is whether P wave is present or not. If P wave is absent, there are only four conditions. That is atrial fibrillation, atrial flutter, hyperkalemia, and junctional rhythm. First we will see two things. Atrial fibrillation and atrial flutter. How to differentiate? In atrial fibrillation also there are no P waves. In atrial flutter also there are no P waves. But in atrial fibrillation, the RR interval is irregularly irregular. But in atrial flutter, there will be regular RR interval will be present. Okay. Similarly, in hyperkalemia and junctional rhythm. In hyperkalemia, as the potassium increases, the P wave become flat. In junctional rhythm, sometimes we see the P wave and sometimes you don't see the P wave. Second thing is we have to look for morphology, whether it is normal or abnormal. If the morphology is normal, we have to look for two leads, lead 2 and lead V1, where lead 2 is important. In lead 2, the height should be less than 2.5 small boxes. In width should be less than 3 small boxes, that is less than 2.5 millivolt and less than 120 milliseconds. In lead V1, the P wave is biphasic because as we know that from SA node, P wave will move like this. That will cause initial positive deflection in V1. Then in left atrium, the P wave will be moving like this. So it will cause negative deflection. So in V1, the wave will be biphasic. Initial positive phase in right atrium should be less than 1.5 mm, and the negative phase, the depth and the width, both should be less than 1 small boxes, that is less than 1 mm and less than 40 milliseconds. If it is abnormal, abnormal in height, abnormal in width, and it can be inverted. If it is inverted, we have to remember two things, that is junctional rhythm and multifocal atrial tachycardia. Junctional rhythm means something has happened to the SA node and the junction, that is AV node, will take the charge. So AV node is producing the wave. These waves are going in opposite direction, so P wave will be inverted. This is inverted P waves. In multifocal atrial tachycardia, there will be multiple points in the atrium will be firing. So some waves will be firing like this, some wave will be firing like this. So different morphologies of P waves are seen. Some will be inverted also. Now abnormal height. Height in lead to greater than 2.5 small boxes, and V1, the positive component, is greater than 1.5 small box, is called P pulmonale. In P pulmonale, there are true P pulmonale and pseudo P pulmonale. For pseudo P pulmonale, remember one thing, that is hypokalemia. In true P pulmonale, there is right atrial abnormality, that is secondary to right atrial overload, which will be secondary to right ventricular overload. It can happen secondary to COPD, interstitial lung disease, pulmonary hypertension, pulmonary stenosis, etc. These are some examples of P pulmonale, which are greater than 2.5 small boxes in height. Then we'll come to abnormal width. We will say it as abnormal when in lead 2 it is greater than 3 small boxes, that is greater than 120 millisecond, and in lead V1, the negative component, we have to see the width should be greater than 40 millisecond and depth should be greater than 1 small box, that is 1 millivolt. Then we call it as P mitral. P mitral is nothing but left atrial abnormality, most probably left atrial enlargement. Now I said something about Morris index. Morris index is nothing but the depth and width of the P wave, that is negative component of P wave in V1, should be less than 0.04 millimeter second. If it is more than or equal to 0.04, it is most probably left atrial enlargement. This is an example of left atrial enlargement.